Thank you, Stu. Really, actually, this is the first time I came to a meeting like this one. So what I'm going to do, actually, the title is a little bit different from what is on the brochure. And in part, it's because I think you all know the good, the bad, the ugly of opioid. And I think what I'm going to do today is actually to introduce you to a concept some of you may be familiar with, some of you maybe not, which actually was developed over the last almost 25 years, so-called opioid-induced hyperalgesia. So what I'm going to do is actually, first off, nothing to disclose. I'm going to actually present a clinical scenario. Then I will basically to describe this concept of opioid-induced hyperalgesia and explain why I think opioid-induced hyperalgesia may be partially at least responsible for the clinical scenario I'm going to describe. So you all know that opioid obviously primarily used for analgesia. And we were just in a discussion a couple of days ago with one of our faculty members. We cannot really think about a potential use for the clinical scenario other than analgesia in terms of opioid medications. Of course, there are other, opioid does a lot of things. Anxiolytic actually is one of the applications of opioid analgesics. Nonetheless, primarily opioid used for analgesia. But the problem, obviously, is that addiction is a major issue, now becomes a crisis in the States, and side effects, obviously, we encounter every single day with the patients on opioids. So let me first describe this clinical scenario. It's not a single case or anything. We just ask this question because we have these chronic pain patients on opioids day in and day out, year in and year out. And we ask this question, say, patients on opioids, if we use a clinical pain score as an endpoint, do they actually change their clinical perception or from the patient point of view in terms of pain score? So we looked at over about 100 patients in our pain clinic over about 7 years. And we divide them into several different kind of groups. One group is that over years, they actually received opioid dose increase. And the other group, they received opioid dose decrease. Now, look at this. So each bar represents individual patients. Over years, they have opioid dose increased. So you can see some of these. One patient had opioid dose increase more than 1,400% over years. But then this little red bar actually is the change of pain score in terms of, we typically use actually numeric pain score. And so you read a lot of papers talk about a visual analog scale. Actually, these two scales are quite different. One is digital, in my view, one is analog, as is mentioned with the VAS. And back in 1970s, 1980s, actually, the implication of using these two different pain scores in terms of assessing pain perception was very thoroughly studied. But in the clinical setting, actually, we don't necessarily separate whether you're going to use a numeric 0 to 10 score or use actually visual analog pain score. Nonetheless, so these are these are numeric pain scores. But if you look at the pain score change, it's almost minuscule. In this patient, for example, with 1,400% increase in terms of opioid dose, the pain score change is almost like 5–10%, almost nothing. Then look at this group. This group have a dramatic actually opioid dose decrease. In some cases, opioid basically tapered off from these patients. And you can see, of course, some of them, they have a pain score increase, but most of them actually have a pain score decrease. And this is actually this is after we had the concept of opioid-induced hyperalgesia. The reason I introduced this clinical scenario is really, I think, opioid-induced hyperalgesia may have something to do with what we just described over here. Now, this is from 100-something patients. Then the same actually study design applied to a separate private practice group in this Boston area. And they have over 800 patients on opioids, and they did exactly the same, almost identical analysis and found exactly the same findings. In other words, number one, pain score change and opioid dose change, they are not necessarily correlated. That's number one. Number two is that in subgroup of patients with opioid dose decrease, you actually see the improvement in terms of clinical pain score. So these are the two, I think, conclusions you can draw from this small study like this. Okay, so I'm going to skip these few. Basically, it shows that it doesn't matter whether this is neuropathic pain or whether this is no receptor pain or this is mixed pain scenario. This kind of situation kind of holds true. Okay, so let's talk about this so-called opioid-induced hyperalgesia. This is a slide actually I made back in 1994. Actually, that's how I launched my research career, more or less. And so this is actually the slide that made in 1994, and I copied. This is the original slide. I copied into this kind of PowerPoint presentation. So I want you to focus on these two groups, this group and this group. So you're familiar with the pore withdrawal latency or tail-flick latency. Basically, the high latency, it means the less sensitive animals to nociceptive stimulation. So at the very beginning, you see these two groups, they have a pretty similar baseline pore threshold latency. And so this is a group actually received intrathecal saline treatment or administration over a 7-day period. And they were given once per day, just a saline injection. And this is a group actually received 10 microgram morphine intrathecal, and also once a day. And so then after 7-day treatment, on day 8, you do the test again. This is what we found originally. There's almost no change, obviously, intrathecal saline administration. And this group has a dramatic decrease in terms of nociceptive threshold. And remember, these rats, all they received is actually morphine, analgesic. They did not have a pain condition. These are naive rats. So this, at the time, we published this paper. The other groups, actually, one group is morphine treated with protein kinase C inhibitor. At the time, it's available as a GM1. And the other group actually is treated with morphine plus MMDA receptor antagonist, MK801. So just keep that in mind, because I'm going to explain why these two elements are important. And so there's a dramatic actually decrease. So in other words, these rats receiving 7-day treatment of opioids, they end up with become more sensitive to nociceptive stimulation. So the question, obviously, you would ask is that because you give it once a day, and then you test them actually 24 hours after the last injection. So obviously, withdrawal needs to be considered. And hyperalgesia actually is a known sign of withdrawal in rats in human beings. So what happened was that if you test them again, a couple of days after the last dose, or actually 3 days after the last dose, and this actually situation still the case. So they still have a hyperalgesia in that regard. And so this is 1994. Then after that, there are at least half a dozen laboratories, both in this country and in other countries, particularly in Europe. They repeated they did the similar studies, and more or less they repeated this finding. A couple of interesting points. Number one, that instead of using boluses in this study, we and other laboratories use the the subcutaneous pump and link it to the intrathecal catheter. So basically deliver a continuous infusion of opioids through these 7-day period, and they found exactly the same situation. And also this is not just morphine. You can do this with fentanyl. You can do this with other opioids. So this phenomenon, at least in animal studies, is quite well described. So this then leads to a very different scenario, because before this concept of so-called opioid-induced hyperalgesia, by the way, the term of opioid-induced hyperalgesia was kind of coined in a way, it's kind of bizarre, because what happened was I was writing a grant, 1994, I think, and it was just an opioid-induced hyperalgesia. So in the sense, so end up we say OIH because we were thinking we'll submit a grant to NIH, so IH sounds close to NIH, so that's how this OIH actually continued. Nonetheless, this concept of opioid-induced hyperalgesia really changed the way how we view in terms of how analgesic tolerance or opioid analgesic tolerance can take place. Because in the past, what we concerned about this is always tolerance. Therefore, desensitization of the central mechanisms, primarily looking at the PD aspect of opioid analgesics. So now we have a so-called sensitization process. Actually, opioid can induce pain or somehow increase pain sensitivity in animals, at least. I give you some data for the human studies as well. So the point is that both desensitization, therefore, the reduced efficacy or effectiveness of opioid analgesic versus actively increase the sensitization or sensitizing the central nervous system responsive to the nociceptive response. Both of them actually becomes a pro-nociceptive process. And the question obviously is why that's the case. So why is our body response to opioid supposed to be analgesic end up actually becomes hyperalgesic? So it took us a few years really to think about, because I now at this stage, not 25 years ago, at this stage, whatever you do, I think in animal studies, in human studies, you always want to ask a question is, what is the biological implication? Why that's the case? It's not the data you just received from animal studies, everything you receive is true. No, you ask why this phenomenon is present. And it bothered us quite a while. Why that's the case? Analgesic, good stuff, end up actually hyperalgesia. So our explanation from the biological point of view is that because pain is such a primitive system, defensive system, our body has to have it. It's not something you can have or you don't necessarily need to have. You have to have a pain system in order to survive. So I think by this angle, looking from this angle, it becomes understandable that why the system actually fights back, continues bombarding the current analgesic effect from exogenous system like opioids. But the question is why and how that is being done. So over the last couple of decades, actually, different laboratories did a lot of studies and they're trying to figure out why that's the case. And we have been focusing on glutamatergic system. And this cartoon actually is going to be kind of interesting. Actually, it took us more than 10 years to put this together. And so you all know that mu-opioid receptor activation is through G protein coupled mechanism, and it's going to open the potassium channel, which can lead to the cell kind of hyper inhibition. And so what happened is that this cell is inhibited. Suppose this is a section, I'm supposed to say this. This is a section of the spinal cord dorsal horn, presynaptic, postsynaptic. So the cell is inhibited. And how can the inhibition itself lead to hyperalgesia? And so what we found was actually MMDA receptor played a very significant role in this process. And you all know that MMDA receptor is a major subgroup of glutamate receptor. And this receptor, to my knowledge, is the only receptor actually is both ligand-gated and voltage-gated. Ligand-gated means that receptor needs to be activated by endogenous ligands such as glutamate. Voltage-gated is that simply having glutamate binding to MMDA receptor will not activate this receptor because it cannot open the complex receptor and the calcium channel complex. Why? Because there is magnesium sitting deep in the calcium channel. So magnesium has to be removed. Magnesium is a 2+ and calcium is 2+. So you have a magnesium in the middle, calcium cannot influx into the cell itself. So under the normal circumstance, actually this only shows MMDA receptor, but you all know there are co-localization of multiple receptors or multiple kind of cellular systems in the dorsal horn. And some of them are co-localizing with substance P receptor or NK1, some co-localizing with the cytokine receptors. So under normal circumstances, in the intact system, what you find is that actually these kind of receptors partially depolarizing the cell membrane. Therefore, it removes magnesium blockade. Under that circumstance, the calcium channel can be opened, so MMD receptor can be activated. But here's the problem. The problem is that with mu-opioid receptor activation, the cell membrane is hyperpolarized. It's supposed to be inhibited. And that really bothered us for quite a few years. And we couldn't explain why, because if you look back, this slide, we did find from the behavior phenotype point of view, if you inhibit MMD receptor, if you inhibit protein kinase C, you can actually prevent the development of opioid-induced hyperalgesia. So how did that happen? There was a paper published in middle 1990s, late 1990s in Nature. It was from Galveston group. And they did something very interesting. It was an in vitro study, more or less electrophysiology study. What they found was that if you use morphine, if you expose the cell with morphine and also PKC inhibitor, you can actually make the cell become excitable. So what does that mean? Is that the major player intracellularly is actually protein kinase C. And you all know protein kinase does nothing but phosphorate proteins. But depends on what kind of proteins are being phosphorated, it will have a different outcome. So in this case, PKC can phosphorate mu-opioid receptor complex, leading to the decoupling of the G protein and the potassium channel. However, if protein kinase C phosphorate MMD receptor complex actually can remove magnesium blockade even when the cell is inhibited. That really solved our puzzle. What happened is that basically repeated exposure to mu-opioid receptor leading to the protein kinase C upregulation and activation, which then removed the magnesium blockade in the calcium channel, deeper in the calcium channel. So now the MMD receptor is primed, is ready to be activated, even when the cell membrane is hyperpolarized. And better yet, we later find that the glutamate once released into the cleft, synaptic cleft needs to be taken back by glutamate transporters. And the glutamate transporters have 5 different types, but some of these types are located presynaptically, some of them located actually with the glial cells. So what we found was that with repeated opioid exposure, actually you see the glutamate transporter number is decreased and activity is also decreased. What does that mean? That means when glutamate is released into the synaptic cleft, it will stay there longer, it will be more available. Now you have it. You have an MMD receptor is primed due to this mechanism. You have an endogenous MMD receptor antagonist, the ligand is more available. So now you can imagine that even with the repeated exposure of analgesic morphine can actually lead to a hyperreactive or hypersensitive spinal cord, dorsal horn. So that is how the repeated opioid exposure can actually lead to the hypersensitivity or hyperalgesia in this setting. So I have, almost 20. So I'm going to go very fast. So some of the human studies actually shows that addicts with methadone maintenance and addicts without opioid addicts without methadone maintenance, actually they have a higher sensitivity in terms of pain response. And so the other, actually, this is probably you're all familiar with this model. Actually, this is the most probably reliable human model in terms of demonstrating clinical opioid-induced hyperalgesia. Basically, it's an intraoperative infusion of remifentanil. And this is actually an interesting story because when remifentanil first hit the market, I was anesthesia resident. And we were all happy because if you do acoustic tumor resection, you can use remifentanil infusion and doing almost nothing. The only thing you worry about is in the afternoon, you're going to doze off, right? But the problem is that very quickly people realize if you don't give long-acting opioids 30 minutes to 1 hour before the ending of the operation itself or ending of the remifentanil infusion, actually have a very tough post-operative management situation, particularly in the PACU. Some of these patients becomes very agitated. So now we can look back, probably opioid-induced hyperalgesia played a role in that kind of scenario. In part, it's because you can see people with intra-op opioids or remifentanil, they actually have more enhanced nociceptive response, and they also use more actually opioids post-operative. 3 minutes, okay. So this is actually, we use a quantitative sensory testing, which is similar like a rat. We did it to the rats, basically look at the baseline nociceptive threshold to the HIT stimulation. And so what we found was that naive, healthy group of patients with chronic pain without opioids, group of patients with opioids with chronic pain, they end up has actually much lower, they have a much lower HIT threshold with regard to the pain sensitivity. So what does that mean? That they feel more likely to feel pain at a lower temperature as compared to the other groups. So this is basically the temporal summation, which actually is a correlate of so-called electrophysiological correlation of wind up in the spinal cord dorsal horn. And this is a psychophysical actually phenomenon in human being. So what we found was that in these patients, they have a chronic pain and also receive chronic opioids. They actually have exacerbated temporal summation. Again, temporal summation is one of these situations in the spinal cord dorsal horn, indicating the spinal cord dorsal horn is hyper-responsive to noxious stimulation. So let me just spend maybe 1 minute on this slide. Why this is important? Because this changes the way we practice pain management with opioid therapy. Because in the past, when we talk about so-called apparent opioid tolerance in the clinical setting, is that the same dose of opioids will not produce the same degree of pain relief. Or in order to maintain the same degree of pain relief, you need to increase opioid dose. So we call this, regardless whether this is a PD issue or PK issue, it doesn't matter. The point is that the same dose is not producing the same analgesic effect. So this is so-called apparent opioid tolerance. So in the past, we always more or less attributed this kind of situation to so-called pharmacological tolerance, Pharmacological tolerance, because the receptor is not responsive anymore, G proteins are decoupled, and there are multiple, actually, there was a paper published in Cell back in the 90s, and because the opioid dimer is not, mu opioid receptor dimer is not being formed, so it's not internalized. So all of these points to that the system is not responsive anymore to opioid analgesic. But this changes. So in order to overcome this, basically what we do, we always have opioid dose increase. And I don't know how many of you are actually managing chronic pain patients. Sometimes we see this patient, they have a combined intrathecal or whatever the source you can give opioids to these patients. They have a combined morphine equivalent dose, the daily morphine equivalent dose up to 1 gram, 2 grams, 3 grams, 4 grams. That's where they are. Because the concept of overcoming apparent opioid tolerance in the clinical setting is opioid dose increase. But this changes. With opioid-induced hyperalgesia, obviously no one is going to do this in a way, in my view. And we often kind of think about this in the setting of infectious disease management. If someone has an infection and you give antibiotics for 7 days and infections are getting worse, of course you're going to reassess whether this is the right antibiotics, have you identified the right bugs, things like that. Same is true with opioid management. I think with this concept, you're really thinking about it, in some cases at least, some of these patients, maybe the way to overcome opioid-induced the apparent clinical tolerance is not to increase dose, but to decrease dose. Now this goes back to that small clinical study we did to look at the child review, look at how the relationship between opioid dose increase, decrease, and clinical pain score change. That makes a lot more sense now. I'm going to stop here. Thank you very much.